Technology. Okay. Oop, there. Okay. All right. So we are officially live. All right. Hello, B Stars family. My name is Tiana Piles. I am joined I'm joined with Dr. Gregory Vidal. Excuse me. I'm one of the co-founders of B Stars. Thank you for your patience with me this evening as we get started. Um, But I'm so excited for our guest that we have, our topic around breastfeeding, breast cancer awareness. Please forgive me, all these breasts and all. So thank you so much for joining us this evening. I'm going to turn it over to Dr. Gregory Vidal from the West Clinic, who is a dear friend and helps us and supports us in his way in his work. And so he is going to share with us some information. So I'm gonna wait a minute. Let me turn this around. Wait, and I want to do this. Yep. Okay. All right, Dr. Vidal, over to you.
All right. Thank you, Ms. Piles, for inviting me. I know this is a long time coming. Um, and hello to everybody out there in internet space. My name is Gregory Vidal, as was said before. I am a medical oncologist and work at the West Cancer Center in Memphis, Tennessee. I specialize in breast cancer. I only see breast cancer patients. I moved to Memphis about 6 years ago from the Bay Area, where I did most of my training in breast cancer. I spend about 60% of my time doing treating patients, and the rest 40% focused on research in drug development, biomarker development, meaning tests around breast cancer. So again, thank you for inviting me this October Breast Cancer Awareness Month. Uh, I was asked to just talk to you about breast cancer and then how it relates to breastfeeding. Um, and so the first thing I will tell you guys out there is that it's true that breast cancer is a deadly disease, and it's scary when you hear breast cancer. But the fact is, we cure most women with breast cancer. The cure rate is in the region of 70 to 80%, meaning 70 to 80% of the patients who present with breast cancer will be cured of this disease. We will treat them, and they will no longer require treatment, and this disease will have been gone away. So, how do we accomplish that? We accomplish that many ways. First and foremost, we need to be able to find the disease early. We cure any cancer once we can find it early, before it is either spread locally, meaning in the breast and extensive. The bigger the tumor, the more lymph node involved, or if it's spread other places. If it's spread in general, we can't cure it. So mammograms are important. That's what mammogram is really good for. It's a very good screening tool, and the measure of a screening tool is not only whether or not it can find the disease early, but that finding the disease early results in reduction in mortality. And mammograms are pretty good for that. It's pretty good at finding disease. Now, my assumption is, since we're talking about breastfeeding, most of the audience may be of a premenopausal age. Most breast cancer occurs in postmenopausal women. The average is right about 60 years of age. It is slightly older in Caucasian women, 60 and above. In folks of color, it's lower, about 55 to 60 years of age. Again, doing mammograms, currently recommendation is at least by the age of 40. Between 40 and 50, there's a little bit of controversy as to who should get screened at that age. The data suggests that between 40 and 50, we really are only saving one life per 1,000. In other countries, that is sort of discouraged. In the United States, we've taken the approach that even one life is important, despite all the additional tests that may come out of that. So doing your mammograms, absolutely important. Uh, Also important is that, especially for folks of color, who tend to have more of an aggressive type of tumor, and by aggressive I mean the cells tend to grow faster. We talk about triple negative type breast cancers. Oftentimes women feel it by palpation, meaning you did a mammogram, or you hadn't had anything in your breast one day, the next day you can feel something in there, and it's biopsied and it's breast cancer and it's triple negative. So knowing your breast is also very important. Uh, Meaning this breast has been with you ever since you were a child. You've gone through maturation with it. Be aware of it. If there's something that is new and different and concerning, bring it to the attention of a physician so that we can find it, deal with it, treat it. Again, the earlier, the better. Now, from a breast cancer perspective, there are really, to summarize, three major subtypes, although there are some gray areas in between. And the three major subtypes would be the hormone receptor driven, estrogen sort of driven tumors. You may have heard of the triple negative, and I'll explain a little bit what that means. And then the HER2. The hormonally driven tumors utilize estrogen and progesterone. And for those of you who don't know what those are hormones, chemicals that your body make that is responsible for you being female. And the breast cells, the breast cancer cells, utilize these hormones as the fuel to the food, so to speak, to continue growing. Those normal cells got an advantage by utilizing this chemical to ignore the control of the body, and that's those cells just continue growing uncontrollably. About 70 to 80% of our breast cancers are estrogen driven. Part of the reason is, your breast is very responsive to the estrogen. During your menstrual periods, or when it's coming on, most women can say they know when their period is coming on because they feel differently in their breast. That's because your breast cells are responsive to varying levels of hormones. So that's one type. The second type is what we call triple negative, and I will talk about that last. Let's talk about HER2. HER2 is the second type that I will talk about. HER2 is a protein that's normally expressed on normal cells, for example, in the breast, in the heart, in the brain, and it's responsible for cell growth. So when that protein is activated, it gives the cell and the nucleus, which is sort of the brain of the cell, the signal to make more of itself. So there is a certain amount that's considered normal. In some breast cancer cells, they've received more than the normal amount of that protein. And because of that, it receives a constant signal to continue growing. And so those cells never stop growing. And that's a more aggressive type. And then the last type, which is triple negative, it's really a diagnosis of exclusion. So when we talk about hormonally driven tumors, we're thinking about estrogen and progesterone. And then we just talked about HER2. So those are three sort of proteins that we look at. When it's not estrogen expressed, not progesterone expressed, or not HER2 expressed, we then call it triple negative. We've recognized that there are probably 5 to 6 different subtypes within that triple negative that we all call triple negative, and we treat them all the same. But really, because we've recognized only these three, and we have targeted therapies for estrogen, progesterone, and HER2, and we don't yet understand what's the cause of triple negative, we call it triple negative. Eventually we will, and there's work being done to try to segregate out within the triple negative different tumors, because we have some triple negative that behaves much better than others. Triple negative, unfortunately, appears to be at much higher expression within the Black population. It's much more aggressive, and folks are much more likely to have metastatic disease with it, and the cure rate is much lower, although we still cure majority of them, but the cure rate is much lower. Those tumors really only sort of systemic, meaning treatment that goes through the body and try to sterilize the body that we offer is chemotherapy. When we let me touch on at least some of the treatment approach to breast cancer. When we see a patient who presents with breast cancer, it's true that the cancer started in the breast. And for most part, and a lot of women come in thinking we just have to treat the breast. So way back when we started really focusing on trying to develop treatment for breast cancer, the first treatment approach was surgery. And you may have seen the pictures of women having really just radical mastectomies, where all of the breast, the muscle, the lymph nodes were removed. In those patients, we still had a high risk of recurrence. It wasn't until we recognized that not only do we have to treat the breast, but we also have to give you something that goes through the rest of the body and sterilize the body, that we started increasing the cure rate. And that's because these breast cancer cells, in order for them to grow, they need blood and they need the nutrients that's in the blood. So they grow in very close proximity to blood vessels. Because of that, they are very likely to shed some of those cells within the blood vessels. And since the blood vessels are connected all over the body, then the cells, oftentimes when you come to a physician with breast cancer, some of those cells have already been let go. So the treatment approach is not only to treat the breast and what's in the breast, but also to give you something that goes throughout the body and try to find those cells and kill it. And that's where chemotherapy may be an option, antibodies, and even the anti-hormonal therapy pill, which once you take in your mouth, dissolve in your blood, and try to locate any of those cells and starve them. And so the approach is almost always local treatment to the breast, which could include surgery and radiation, but also important is systemic therapy, because that's really what cures you. Anytime the cancer leaves the breast and finds itself growing some other place, we cannot cure it anymore. And so our approach is to prevent that from happening. Okay, I will touch on surgery options. What we know for surgery options is that lumpectomy, meaning just removing the lump and making sure that you've removed all the tumor, plus radiation is equivalent to removing the breast. So for the appropriate patient, you don't need to have your breast removed. I know a lot of women tell me that's where it starts. If it started in the breast, if I am to cure this, I need to remove my breast. The studies show that even if the tumor starts in the breast, 95% of the time, if it's coming back, it's not coming back in the breast. Again, if you are able to have the appropriate surgery and radiation to the breast, if you had breast cancer, 95% of the time, it's not coming back in the breast. If it's going to come back, it's going to come back somewhere else. So removing your breast in order to lower your risk really doesn't make sense mathematically. So as long as you are able to have a lumpectomy with radiation, you should take that approach for most women. I will say about 10% of our breast cancers have a familial risk, meaning we can identify a mutation in the DNA that put that patient at risk for mutation. For those patients, particularly the ones with BRCA1 and BRCA2, especially for BRCA1, their risk of developing a new breast cancer, because every single cell has that mutation, is higher. And so for those patients, if they've chosen to have mastectomies, the data supports that, because again, their risk of developing a new breast cancer is much higher than average. And so except for that 10% of the population for whom making a choice for removing the breast has strong data because of your risk. For most folks, if you can get a lumpectomy plus radiation is equivalent to mastectomy. Now, let me piggyback on sort of breastfeeding, since that's what we're talking about. How can you reduce your risk of breast cancer? As I said before, only about 10% of breast cancers have identifiable changes in DNA that we can identify viable changes in DNA. The rest, we don't really know. We know that with age, there are lots of damage that occurs in the breast cell. Those damage, because again, the older you are, the less again, not only are you older, but your cells and the machinery that repair the cell is older. So the more likely that there will be errors in repair, especially of the DNA. Those errors then lead to cancer cells. But there are a lot of environmental factors that can be modified to lower your risk. One of them is alcohol. Drinking 2 or more alcoholic beverages a day increases your risk of developing breast cancer. Exposure to estrogen. Again, hormone replacement therapy, especially with progesterone and estrogen, tends to increase your risk of breast cancer. Overall, a woman with a higher exposure to estrogen is at a higher risk. By that I mean, if you started your period earlier than 12 years old, then in your lifetime you would tend to be exposed, have a higher exposure of estrogen. If you have a late menopause over your lifetime, higher exposure to estrogen, higher risk of breast cancer. If you've never had kids, remember, every time you have a child, you have a break from estrogen. Those folks who've never had kids tend to have a higher risk of breast cancer. If you've breastfed for longer than 6 months, or breastfed the longer you breastfeed, again, when you're breastfeeding, you're actually, again, keeping estrogen at bay, and that sort of reduces your overall exposure to estrogen. In fact, some of the data show really strong correlation between breastfeeding greater than 6 months and reduction in risk for breast cancer. Some data suggest for every 12 months of breastfeeding, there's a 4.3% reduction in risk for breast cancer, for example. And the belief is that, again, over that period of time that you're breastfeeding, you're reducing your exposure to estrogen. But also some studies suggest that during pregnancy and during breastfeeding, you're also shedding breast cells. And the belief that some of those breast cells that are being shed are the older cells, the ones most likely to have the errors and the damage, and probably would also, because you're shedding them, you're less likely to be in the breast and to cause breast cancer. And so just to bring that back to the breastfeeding, those are some of the benefits of breastfeeding and risk lowering. To just to extend that a little bit, there's also a belief that breastfeeding can lower your risk of ovarian cancer. The same sort of mechanism, meaning you lower estrogen, the ovarian, you prevent ovulation, the ovaries are not working as much, they're less likely to develop cancer. And so that's some of the benefits for breastfeeding. There was an Australian study that looked at breastfeeding for 13 months versus 7 months, and what is the likelihood of developing ovarian cancer, for example. And they found that there was about a 63% less likelihood of developing ovarian cancer if you breastfed for 13 months versus 7 months. We know that breastfeeding, for example, in kids, also there's some benefit. With kids, it's believed it's more theory than having proven by fact. But kids who are breastfed tend to have a less risk of obesity, and then there are cancers associated with obesity. And the thought is those kids would then have a lower risk of developing cancers and other um, types of diseases. The one other thing that I would talk about is in pregnancy. So we know I spoke earlier about having multiple pregnancies tending to lower your risk of breast cancer, but it is the hormonally, it's thought to lower the risk of the hormonally driven breast cancers. And some studies actually suggest that it may actually increase the risk of the non-hormonally, like the triple negative breast cancers. But when some studies have looked at even in the patients who've had uh, increase in the triple negative breast cancer, if you breastfed, it lowered your risk of developing triple negative breast cancer. So again, let me see if I breastfeeding lack having more babies tend to lower your risk of estrogen receptor positive breast cancer, but it may have an increased risk of having non-estrogen driven breast cancer. But if you breastfed, it reduces your risk of having even the triple negative breast cancer. So those are all benefits of breastfeeding. Um, and so again, I can continue talking forever. Uh, I would go back to Miss Piles to see if there's any particular questions that you have for me.
Okay. All right. I'm
Hello,
up.
you're dark.
Uh-oh. Can you hear me?
I can hear you. I can't see you.
I don't know why you can't see me. Well, then I just will remain dark as long as you can see me. That is what matters. I
Yeah.
appreciate that. We appreciate that. B Stars breastfeeding sisters that are receiving support. We strive to make sure that our members have the very important information around breastfeeding and family health for our meetings. And of course, now we're doing this in our virtual capacity. And so, with this being Breast Cancer Awareness Month, it was important for us to be able to share with our members um, the information around there, the correlation between it, and just to be able to support. We have quite a few members who have either dealt with breast cancer, and of course, our group is for Black women and their families, and so or have it. Within their family, close in their family. And so, they remain in our prayers and we try to support them as best that we can. But also just being aware and knowing how to support. Um, um, and also just as we do our checks of ourselves.
Mhm.
What should we be looking for to make sure that our breast, especially while breastfeeding, they're already lumpy, they're a little different. Some people may be concerned with mastitis, but even think it may be a breast cancer. Well, how would you suggest a mom do her exams?
Yeah. So currently, the guidelines, the data, I should say, does not shows that breast exam really does not affect survival for the average risk patient. So self breast exam is um, one of the recommendations that was removed from the last updated recommendation from United States Preventative Task Force. But again, it's for average risk women. For women of higher risk, for women who can't get mammograms, for example, breastfeeding women, breast exam becomes absolutely important. Uh, when I remember when we were first learning about breast exams and what we're going to recommend for women, it is this whole complicated go in circles around the breast and make sure you cover. Really, it doesn't have to be that complicated. You know your breast. Don't be afraid of touching your breast and try to cover everywhere. And again, if something is abnormal, um, bring it to the attention of somebody, especially if it's not going away. if it's getting bigger. So again, I would just encourage folks to familiarize yourself with your breast. Now, for a breastfeeding woman, it's even more difficult because that breast tissue is packed with milk and it's usually expanded. And so it's difficult to differentiate something that's abnormal within that. However, for some women, there is some pain. You can feel the breast being one breast being slightly harder than the other one. So again, symmetry is important. If in one breast it's harder, it's redder, then or no, you have lymph nodes on your arm that are swollen, then that is something that you need to bring to the attention of a physician. Sometimes the breast, you might think it's an infection like mastitis, and mastitis is a true phenomena, and it's more common in breastfeeding women than it is breast cancer. So more likely than not, it would be an infection. However, if you think it's an infection, you've gotten antibiotics, and antibiotic does nothing to it, then that should give you a sign that, hey, maybe I should take a closer look in there and ask your physician. I took 2 weeks of antibiotics. It is supposed to get better. It didn't get better. Should I consider doing a mammogram? Should I consider having somebody take a closer look at it? Because that's important. Importantly, if you have breast cancer, if you've developed breast cancer during pregnancy, there are treatment options for you. There are some chemotherapies that are safe during pregnancy, especially mainly in the second trimester and older. So please don't believe that we will be hurting your fetus if you do have if you are develop breast cancer during pregnancy, because they are means of protecting the fetus while treating the disease. Because we want to make sure that not only the fetus survive, but you are there to take care of that child to adulthood. Okay, and I hope that addresses your question.
Oh, no, it does. All right, all right. Thank you for that. Thank you for all of that information. I have, when we first met quite a few years ago now, and we talked about it. It was just interesting to come to learn that estrogen, although it is one of the things that help us develop as women, it also ages us and also can cause certain cancers. And so the fact that with having children, breastfeeding, puts a space, stops that for a moment in time and actually helps to increase our chances of developing certain breast cancers. That was just amazing to me, just us as women doing what some of us do. So that was encouraging.
Yeah.
So in terms of like the triple negative, I know that tends to run a little bit higher in women of color, Black women.
Yeah.
Um, and then also a little younger as well, correct?
Correct.
Okay, okay. So and triple negative, that is something that runs in people's family. Is that correct? Or can a woman have it that didn't have it in her family line?
Yes, they can. A woman can have a triple negative that never had it in their family line.
Mm,
What we know is if you have the BRCA mutation,
mhm.
there's a higher proportion of triple negative within folks who have BRCA mutation, but there's also estrogen positive within that also. Um, so it doesn't necessarily have to be triple negative to run in family lines.
Okay, okay.
And the whole triple negative thing is it's really just biological. We don't quite understand it yet. When we um, uh, take into account other factors like environmental factors, socioeconomic factors, we still find folks of color tend to have triple negative, and it's just biology.
Mm,
And the more we look into it, that's some of the work that I do and some of my collaborators do, trying to figure out exactly what it is about um, us as folks of color that puts us at risk for these type of tumors.
I see. I see. And so that is one of the reasons why we continue to be blessed in having you in this work, fighting for us and trying to find out some things in the world of cancer that still are mind-boggling.
Yeah.
And just know that are doing what you do best in helping to come up with some answers uh,
Yeah.
and help us to live longer, healthier lives. So I definitely appreciate you for all that you do. No pressure,
Oh,
just,
pressure.
you doing
I,
it.
I appreciate it. There are lots and lots of folks like myself who've been doing this many years before me and continue to do it, and are better at it and more apt at it than I am. Um, and but we've made a lot of strides, and we will continue to do so.
Okay. Let's see. I have a question. Let me answer this.
Hmm.
Having PCOS increase
Uh-huh.
chances of breast cancer, or is there no correlation?
PCOS, I think, has a correlation with uterine cancer, not necessarily breast cancer. I
O-
don't know of any data to suggest increased risk of breast cancer with PCOS, but
Okay.
there is, I think, a higher risk of uterine cancer
Okay.
with PCOS.
Okay, awesome. And again, some of our viewers, they're tuning now and they're waving and they're thanking you for giving such great information. And we get questions live, but we also get questions as people tune in as they can. In this virtual world, they can watch it as part of the Mommy Milk Club at midnight. And so, I wake up in the morning and there's been like 20 more views, so which is amazing. It's a mixed blessing of being able to reach more people.
Yeah,
Well, I appreciate you being willing to take some time out and share this information, help us to celebrate and support um, Breast Cancer Awareness Month. And I thank you so much for your time.
you're absolutely welcome, and thank you for inviting me.
Absolutely. All right, so I'm going to end the broadcast, but don't hang up yet because I have one more thing I want to say to you before we close out. Because I have to grab you while I can.
I get it.
B Stars, thank you so much for joining us. I hope that you found this informative. And as we're closing out Breast Cancer Awareness Month, of course, this is the month for awareness, but that doesn't mean it goes away, just as with the other things in which we support near and dear to our hearts. So just make sure that you are doing your best to support and love on your sisters as you can in the many different capacities in which we do. Know that I remain okay, hanging on in there, and I hope that you and your families are doing well as well. All right, well, have a good evening, and we will join you in two more Wednesdays, the second Wednesday of November. Can you believe it's November almost already? And we will join you for the second Wednesday as well as I think the fourth. I'm not sure if we'll change that, being that it's close to Thanksgiving, but I'll let you know as soon as we get that situated. All right, well, take care, and we will talk soon. We'll see each other soon. All right, okay, closing out there.